Gladys, everyone. Thank you for having me here today. Just as a pointer to begin with, this is hugely out of my comfort zone. I don't talk much. I'm a major introvert, so to stand here in front of all you lovely people is a personal achievement for me, even if I am talking rubbish. You'll have noticed in the biography that whilst I am a mental health professional, I'm not the kind that usually publishes papers or presents at conferences. I'm a mental health nurse. And in the UK, our place is not in research. But going back to some of the themes from yesterday, I love what I do, but I hate my job. I love helping young people understand themselves. I enjoy supporting them through a difficult time, and I'm motivated to help their families understand them as well, and what they're going through. But I don't love the strict rules, guidelines, and policies which often say I can do 4 to 6 sessions with a young person and then discharge if no improvement. My passion is advocacy for young people and ensuring that their voice is always heard. All that being said, I should give you a little insight into the NHS because I realise that a lot of people here have different healthcare systems depending on where you're from. So this isn't the absolute, but it's more or less. So in the UK, we don't have health insurance. We don't pay for healthcare. Oh. Nobody has to. So we pay our taxes, and a big portion of that goes to the National Health Service, or the NHS, so that everyone can access free healthcare for everything, including psychiatry. In many ways, that's amazing, and we are very, very lucky to have this service. But what it does mean, at the moment in particular, is that waiting lists are monumental, services are stretched, and the NHS is chronically understaffed. This leads me on to my topic today, diagnosis. In young people's psychiatry in the UK, most psychiatrists will tend to avoid a psychiatric diagnosis wherever possible. A diagnosis is more likely an ADHD or ASD, but people are facing around an 18-month waiting list for an assessment. And then there's likely no intervention available, even if they have the diagnosis given. My systematic review, my first publication as of last week, explores the literature which focuses on experiences of psychiatric diagnosis in young people, family members, and professionals to identify whether this is good enough for young people and their families.
If you get through the 18-month window and you're diagnosed, you only get 6 or 8 sessions.
No, you don't get the 6 or 8 sessions either.
Oh.
You will get diagnosed.
You will get the diagnosis. That's it. Unless your functioning is of a level where, yeah, I did. I pointed at the laptop.
No, not to the laptop.
Luckily, I only have 5 slides. So, if their functioning is at a level that's causing them or other people, if they're making a big impact on their functioning, then they may get the 6 to 8 sessions or whatever it is, because of their functioning or their risk or their behaviour. Not because of their diagnosis. No. Thank you. So, the importance of diagnosis cannot be overstated in the field of medicine. It can help identify the underlying causes of an illness, predict outcomes, assess the severity of the condition, and recommend appropriate treatments. But diagnosis in psychiatry remains a topic of debate, and this is specific to the UK, some of this. While psychiatric diagnosis can be challenging, it can also provide a pathway to greater understanding, support, and hope for recovery. It's important to acknowledge the potential for exclusion and stigma, but we should also recognise the positive effects that come with a diagnosis. It's vital to ensure that everyone, regardless of age, has access to the resources they need to thrive. So over half of all mental health disorders in the UK begin before the age of 18. Studies also suggest a rise in mental health problems in young people over the last decade, which has been exacerbated by the COVID-19 pandemic. And while some research has addressed the unique stigma experienced by young people with a psychiatric condition, No other review considers the diagnostic experience. So how many people in here, you don't have to disclose what exactly, have a diagnosis of something? Anything. So like, it can be physical, mental, anything. And I think that it's fair to say that being given that label by a doctor or whoever can be quite life-changing, because all of a sudden you're a person with a thing, instead of just all the stuff that you don't have a label for. So there are complex and different relationships between parents of adult children and parents of under 18s. And this can present as a power imbalance within paediatric healthcare. One large-scale review identified the need for a holistic and individual approach to psychiatric diagnosis in adults. But we don't have something similar, or we didn't have something similar in young people. So in October 22, we searched 6 databases using a title-based approach for relevant terms to limit irrelevant articles. And this review considered mental health disorders defined by the ICD-11 or by the DSM-5, excluding neurodevelopmental disorders as the primary diagnosis. So the most common diagnoses in young people were depression, anxiety, eating disorders, conduct disorders, obsessive-compulsive disorders, and substance misuse disorders. Other conditions such as bipolar, trauma, and psychotic disorders were all included due to the common grouping together of mood or emotional disorders. And although there are lots of debates about diagnosing personality disorders in young people, the research team decided to include them in the review because there was such a vast amount of literature on personality disorders in teenagers. There were disparities between countries, so I didn't base it in the UK. I based it around, internationally. And the impact of COVID-19 made a big difference on symptom research as well. So it was challenging to gather precise data on diagnosis prevalence. So in the USA, the prevalence of bipolar disorder in younger children is much higher than in the UK, where we consider it to be sort of a 0.1% of the childhood population would have that. And that comes down to diagnosis and the fact that we will avoid it, but also different classification systems and that sort of thing. So this study used a convergent integrated approach to evidence synthesis by transforming numerical data into textual descriptions to combine qualitative and quantitative data. And this method was used to prevent errors from occurring during data transformation. The responses from participants in survey studies were described using text instead of numbers. And although controversial, this approach is supported by those who use numbers in qualitative research. And all of the studies were checked for quality using 2 different checklists and had to score over a certain level of quality in order to be included in the study. So I won't go into the details of the methodology too much because that's the boring bit, really. I've gone too far now. Okay, so on to the results, which are a bit more interesting. So out of 471 studies, only 13 were then included in the final review. So that means there's only 13 studies which looked at young people's experience of being given a label in psychiatry throughout the world. I didn't put a time limit on it either. So that's going back, obviously there wasn't much research on it in the 1800s, but technically that could have been included too. The studies were qualitative, quantitative, and mixed methods. So every study was involved. The quantitative studies tend to score lower on quality appraisal than the other types, mainly due to them being surveys, usually run by professionals. And this systematic review used a mixed methods approach, resulting in different characteristics among the included studies. So some studies had variant, so that some studies had 8 people included and some people had 300, depending on what group they were looking at. So only 2 out of those 13 studies included caregivers and young people in their research. They were asking about the diagnostic experience of young people, and only 2 of them bothered to ask the young people and their families. Studies were conducted in different countries with different healthcare models, with most studies focusing on professionals from different disciplines. Almost half of the studies focused on borderline personality disorder, while some studies included neurodevelopmental and learning disability diagnoses as well as mental health diagnoses. And so from this, 3 overarching themes were identified, with sub-themes spanning all 3 groups: young people, caregivers, and professionals. So the first theme is diagnostic subjectivity, and this can be split into 4 sub-themes. The first is accuracy of diagnosis. It's been found through studies that diagnosing a person's psychological state with accuracy is a complex issue. Professionals question the validity of diagnosing young people, and some argue that it suggests something is wrong with them rather than recognizing maltreatment. Young people, however, often feel that a diagnosis is the most accurate way to describe their symptoms. A diagnosis can cause mistrust and annoyance, and changing it or removing it can create problems for caregivers. So, where that comes from is that young people often find it much easier to say, I have OCD, I have depression, I have an anxiety disorder, rather than saying, well, actually, I have lots of thoughts that make me do these certain behaviors, and kind of it going around in a kind of a long-winded way. It's easier for them just to say, I have X, Y, Z. And when professionals kind of get involved and will change that or add things on and take things away, that can make them feel really disconnected from a label that they've been using for such a long time. The second sub-theme is alternatives to diagnosis, which professionals love. So as a result of the contested accuracy of diagnosis in young people, many professions have found alternative ways to describe symptoms of a mental health condition in adolescence, with a particular focus on formulation. Psychological formulation is the development of a narrative to help understand a person's difficulties, bringing together theory and individual experiences to provide tailored support. But when separated by profession, different disciplines focus on varying aspects of a young person's illness instead of their diagnosis. Nurses, like me, tend to focus more on behaviour and symptoms and what someone's showing you, while psychologists tended to focus more on the patient's story and their narrative. However, one study identified that in the absence of a formal diagnosis, different descriptors were used by staff that could be both helpful and harmful, and informal conclusions were likely drawn. Some studies also suggest that withholding a formal diagnosis can lead to several informal, inappropriate diagnoses. One study identified that psychiatrists disagreed with using hedge terms such as emerging or traits of, due to concerns that these would lead to informal labels. And to give a little bit of kind of clinical experience, when I've been working on the ward, if a young person doesn't have a diagnosis, you will often hear the nurses or kind of, support workers or anyone in the team sort of saying, oh, they've got BPD, or they're severely depressed, something along those lines. And actually that young person doesn't have that diagnosis, and how difficult that can be for a young person to overhear those kind of conversations when they've never been directly told that, and whether it's even correct. Then the study considers avoidance of diagnosis. Professionals have inconsistent approaches to delivering psychiatric diagnoses to young people. Some avoid giving direct diagnoses, whilst others share limited information based on their perception of the family and young person. And whilst it's mentioned that professionals provide a diagnosis in this way to soften the bad news, there is also evidence to suggest that they do this because of their own emotional attachments, with professionals identifying feelings of sadness, sorrow, and grief during the process of diagnosis delivery. But it's not their diagnosis. However, other studies identify frustrations in professionals when a diagnosis is avoided, suggesting it's a bit cowardly not to give a diagnosis just because it's difficult for the professional. And the final sub-theme within diagnostic subjectivity is the power of professionals. One study identified that psychiatrists usually feel that their decision would trump the patient's input, despite discussions about person-centeredness. However, the review did recognise professionals experience greater distress when caregivers of young people disagreed with their child's diagnosis. And despite the confidence of psychiatrists in their role, discussions with wider professions face some doubt on that authority, often resulting in a powerful tension within teams. And this tension seems to be misunderstood by psychiatrists who identify conflict as a sign of a healthy team. And wider groups of professionals such as psychologists, therapists, and psychiatric nurses identify they're in a difficult position between professions, which can be confusing. And studies identified that professionals did not necessarily agree with a psychiatrist's decision not to provide a diagnosis, but would be unlikely to voice their concerns. Okay. However, other studies identify this as an old-fashioned dividing of roles less prominent in modern-day psychiatric care. And one study, which wasn't based in the UK, surprise, surprise, recognised a working method that held all clinicians accountable for diagnosis, and clinicians were expected to make psychiatric diagnoses regardless of clinical background. Obviously, there was lots of training, and the psychiatrist's input wasn't vital. So there may be that when things are very clear cut, other members of the clinical team would be able to make that diagnosis. And then when things are more complex, it might be escalated up to psychiatry. The other thing is that because of the limited resource in the UK and the waiting list, etc., I currently work in an eating disorder service for young people under 18. And I work part-time, and I've got a caseload of about 20. Only about 4 of them have actually seen a psychiatrist, because unless you need medication, why would you see one? And that's how it works. So the other 16 have no kind of diagnosis at all, and they've never been assessed for one. So whether they meet criteria or not, no one's ever looked at it. And they will often ask me, well, what's wrong with me? And I can hedge around it, but I can't tell them this is what you have, because that's not my role. Despite the fact that I know them much better than most of the psychiatric team, because I see them all the time. The next overarching theme is that of utility of psychiatric diagnosis, and this can be divided into 2. So the first is access to support and treatment. Several studies recognise that an accurate diagnosis is a vital aspect of professionals' treatment planning, with many reporting that they felt a diagnosis was necessary to provide appropriate intervention. But it's also apparent that diagnosis is meant to be a guide to treatment planning instead of the deciding factor. And we talked, I think, about how, technically this is the treatment for major depressive disorder. However, that doesn't work for everybody. And sometimes we need to use other methods depending on that person and their symptoms. And sometimes we need to be guided by them. Other studies identified that it empowered staff to provide interventions. So some studies suggested that when a young person has a formal psychiatric diagnosis, it's easier for their caregivers to explain the difficulties that the young person is experiencing and made treatment planning less complex. This simplified way of communicating difficulties is considered a positive by professionals and caregivers alike, which I thought was really interesting, because professionals felt like that and still didn't give one. The young people often found that having a diagnosis allowed them to accept and understand interventions, even when the diagnosis was not necessary to access them. And that occasionally they felt that diagnosis could exclude them from further mental health treatment. But some studies recognise that whilst diagnosis may not be necessary to access interventions, it was required to secure funding for other support, particularly social services and education. So the way the UK education system works, if a young person has traits of autism, they don't get any extra support unless they have a diagnosis of autism, which is fine, except for the fact they have to wait 18 months for that. So what do they do in that time? Lots of them don't go to school, or they go and they don't perform very well because it's not set up for them, and yeah, it's a bit of a mess. And obviously we're trying to make the waiting list less, but I've been in practice for 8 years and it's not really changed in that time. The next sub-theme is understanding of self, and this one that was really important for me. So O'Connor and Nicholas reported that young people and caregivers often feel relieved due to their diagnosis. Some studies also found that being given a diagnosis supported other people in understanding the young person. And although there was some reports that this support and change make feel uncomfortable because it makes a person different because of their diagnosis. But often the young people will say, well, I was different already. At least now I know why. Although some studies identified that diagnosis improved understanding of mental health difficulties, one study also found this was hampered by a reluctance to accept the diagnosis. And professionals identified that it was important that young people and families had some input into the decisions, although this was often informal and based on what professionals felt the families would want. So it was professionals making decisions on behalf of the families without actually asking the families, just going off assumption. Some noted the professionals make assumptions about what family members want to know based on their clinical and personal experience. And then the final theme is stigma. Frequently, professionals have identified that they feel a psychiatric diagnosis includes pejorative or value judgment, which can further stigmatise patients. Professionals reported that they use diagnostic labels to describe patients, but some clinicians use the label as a way of opting out of working with some young people. So they can't be accepted into this group because they've got borderline personality disorder, the usual one. And some research identified concerns that people would be stigmatized by others if given a label. However, young people's experiences were directly related to acceptance of diagnosis and perception of self. One study found that young people were more likely to notice being treated differently by caregivers following a psychiatric diagnosis than by professionals or by their peers. And this may be explained by O'Connor and McNicholas finding that caregivers experience stigma because of their child's diagnosis. An unwillingness to accept the diagnosis due to perceived stigma was also evident for caregivers who experienced shock following the psychiatric diagnosis. And these concerns led to caregivers and young people keeping the diagnosis for themselves, which included caregivers not sharing the diagnosis with the child. And I felt that was really shocking. In that, the professional would sort of say, "Oh, your child has OCD." The young person would not be in the room, and they would never know. They were never told. And some of these young people are 14, 15. They're not 6. They're old enough. They're the ones going through it. So.
Over 12 they had people.
Mm-hmm.
It's their choice to be parents.
Yep. So both young people and caregivers expressed feelings of failure following a psychiatric diagnosis. And for young people, this was a feeling that they'd failed other people by becoming unwell. For caregivers, it was a sense of failure angled around the feeling that they hadn't done enough for their child. But also it was identified in professionals who showed that they will try to alter how they deliver a diagnosis to children to ward against feelings of failure. So for example, they will, instead of saying, "You have anorexia nervosa," they will say, "You have a type of eating disorder that means that it can be really difficult for you to eat." It's not incorrect, but it's not as clear as the label would. And often it invalidates young people because they feel like, "Oh, I'm not unwell enough yet." Oh, sorry.
I'm surprised about what you're saying. So after the pandemic, it's well known, there are figures about how the young people are most affected in their mental health. And even the numbers are more worrisome about suicidal.
Yep.
Suicide. And then you said at the end, even though that's out there, like nothing's being done. That's what you were saying.
No. So there's, in my service in particular, just going off clinical experience, we had a 106% increase in referrals during the pandemic, and it's sort of not really gone down that much even afterwards. And there are lots of resources poured into early intervention and quicker assessment and trying to treat more people. But because of the way the service works, we don't have any more resource after the pandemic. The resources are the same. We're just trying to stretch it in different areas, which means that we can, so in my service, we assess people within 4 weeks, and then they wait another 4 weeks for treatment. But if in that time they're not willing to, they're not ready to engage in treatment, or we're not showing any recovery, they get booted back out again, because we have to go on to the next one. We have to work through those numbers.
They're not working, for example, with anorexia.
Well, no. I mean, it's well known that anorexia takes a minimum of sort of 6 months to 18 months to sort of have any kind of recovery, often because they don't even recognise that they're ill. 4 to 6 sessions doesn't even scratch the surface. Yeah, so it's a kind of a unique problem to the UK in that our resource hasn't changed, and actually there's more pressure, but no more staff, no more interventions, no more.
So it doesn't matter if they were out there, resources that are not there, even if you start there. But that's not the thing. Doctors come out of the woodwork.
I think you'd be surprised, because the doctors and the nurses are constantly striking because they don't get enough pay. They don't pay enough. They're not, none of that stuff. So I think it's if we had private healthcare, we might be more likely to train doctors and nurses who actually wanted to go into a career that they felt was lucrative. But the numbers of nurses and doctors in the UK are dropping because it's not a very attractive career. It's long hours, it's hard work, and there's, it's just above minimum wage.
So people have the feeling that they should get support from NHS, so I'm not working with the girls and ladies with eating disorders, and And it's kind of like even that acceptance that they need to go private because they don't get things. And so I'm on the waiting list. It's like, what are you waiting for? You will get diagnosed, but you will not get any treatment. And if they get treatment, they get self-help booklet. It's like if I were able to deal with that self-help, I will not go for diagnosis. That's that issue that on our side is creating that belief that it should be provided and it's not. So even that shift of like you need to go search for help.
Our actual intervention guidelines say that in mild to moderate eating disorders in particular, it's self-help.
Yeah, that's not.
Hmm?
What, can you repeat that?
So in eating disorders in particular, our guidelines say that for mild to moderate eating disorders, self-help is the answer. And then if that doesn't work, you can try group therapy. But for an adult, for you to have like one-to-one intensive treatment, you've got to be quite down the high end.
I will be dying in hospital.
You have to have a BMI of under about 40.
So it's really political whether anything can change.
It's interesting hearing you guys talk about your careers and things and mentioning, so you said earlier, oh, when I go to my therapist kind of thing. That is just not that. Like,
Really?
To admit that would be like hugely, like, you just don't admit that.
Going to shame?
Yeah.
Wrong.
You have to be sort of the most poorly of the poorly. You can't just be someone who goes just for self-care or just to, because you need a bit of a pick up. You need to, or you find it useful to continue with your job. That does not, that culture does not exist.
Wow.
Yeah.
I didn't